Hello everybody and welcome to the Social Market Foundation SMF fringe event with Novo Nordisk. Thank you very much for tuning in. We are going to talk about obesity today and in particular the links with poverty. And we have three speakers who are going to give us their thoughts. First we have Scott Corfe, who's the Research Director at the SMF. Then we have Avideh Nazeri, who is the Director of Clinical, Medical and Regulatory Affairs at Novo Nordisk, which is sponsoring today's event. And finally, we have Councillor Paulette Hamilton, who is the Chair of Birmingham Health and Wellbeing Board, the Vice Chair of West Midlands Combined Authority Health and Wellbeing Board, and Vice Chair of the Community Wellbeing Board at the LGA. So she's already won a prize for the biggest title, but we'll start off first with Scott, please.
Great, thank you, Ross. So I'm going to bring up some slides, which hopefully everyone will be able to see. Great, can you see the slides?
Great. Yes.
Perfect, so I wanted to give a very quick canter through some sort of facts and figures about obesity and inequality, and that's drawing on some of the official statistics on this and also some new survey research that we've commissioned from Opinion. So thank you for Novo Nordisk for sponsoring this event. So the first thing I want to highlight is how sort of obesity contributes to inequality in the UK. If you look at a map of obesity and overweight rates across the country, it's clearly unevenly spread, and obesity is much more prevalent amongst lower income and more deprived parts of the country. And you can sort of see this on this map, sort of the red areas, bits of England where obesity rates are higher than the average, yellow is where it's similar, and green where it's below average. So you've got places like Hull, you've got some deprived seaside towns in the southeast of England, and quite a lot of the Midlands of the UK. So there is this sort of regional dimension to it, and you can see more of the green, the areas where obesity is less prevalent in sort of the home counties around London. And if you compare obesity overweight rates against measures of health deprivation, so the ONS produces its indices of deprivation, which measures all sorts of things like income inequality, crime, but also health. What the data suggests is obesity and overweight rates explain about 20–25%, about a quarter of the variations in health inequality across the country. So it accounts for a very big amount of the health inequalities in the country. And if you look at some of the studies around how obesity impacts health, then there's some really stark figures. So a recent study showed that about 14% of all premature deaths in Europe and North America are due to excess weight. That's the second biggest cause of premature death after smoking. And also there's emerging evidence that not only does being on a low income or being in a deprived area result in a higher chance of being overweight or obese, but also the causation can run the other way, is that if you are living with obesity, you're more likely to be on a lower income, and that reflects some of the factors such as stigma and how that affects people's job opportunities. And it also impacts how health can impact the ability of someone to work. So if you're in poor health, you're more likely to drop out of the labour market. So not only does being on a low income or being in a deprived area lead to higher rates of obesity, but also higher rates of obesity lead to lower incomes. So causation is running in both directions. So when we're thinking about inequality and obesity, it's not just health inequality, it's also income inequality too. And I think there's a real risk here that COVID and its impact on decision making could lead to a further widening in health inequalities in the UK. One thing we asked in the Opinion survey was how people were changing their behaviour in response to COVID. So a lot of the emerging evidence around the health impacts of COVID-19 suggests that excess weight, obesity is a risk factor. And what we see in this graph is the pink bars show individuals saying that, yes, I have taken steps to reduce weight because of coronavirus. And the highest proportion there is London. Over 25% of survey respondents said that they were actively taking steps now to reduce weight. And then you can see towards the right of that graph, areas like the Northwest, Yorkshire and Humberside, the Northeast, having lower rates of people that are actively taking steps to reduce their weight. So going back to that earlier map of what are the parts of the country where rates of obesity are higher, you could easily envision a scenario where this kind of behaviour pattern leads to a further widening in those health inequalities that we observe. In terms of what's driving higher rates of obesity over time, if you go back to the 1980s, early 1980s, about a third of the population were either overweight or obese. The latest data suggests it's over 60%. We've asked sort of survey respondents what they think are their main barriers to losing weight. Willpower sort of comes up as the strongest item in the survey, but then sort of followed by that, things like the convenience of unhealthy foods, lack of time to exercise or prepare nutritious meals, the cost of healthier food, or people that have medical conditions that make weight loss difficult. So obesity is complex, and the drivers of obesity are a wide range of factors, which raises questions around what government should do, and to what extent is there likely to be political and electoral appetite for the government to make more of a priority of obesity. We've seen the government is starting to take obesity more seriously with the announcement of a new obesity strategy. Does that have political support? What does the electorate think of it? So in our survey, we've posed a number of statements to survey respondents, and we've asked them to what extent they agree with these statements. I think something that really comes out of the survey is actually a clear majority of the population agree that obesity is a complex condition with many causes, that people need help to lose weight. That has a much stronger agreement than statements such as people with obesity only have themselves to blame for their condition. So the public at large don't just think individuals need to deal with obesity themselves, but there is a role for government to play in addressing it. And actually, the view of the electorate is more nuanced than that sort of blame game of pointing fingers at people and sort of making them feel guilty into losing weight. There is a recognition that there is a role for government to play. And we asked survey respondents how they felt about some of the measures that have been announced as part of the obesity strategy. So things like putting calories on alcoholic drinks, restricting buy one, get one free offers on junk foods, curbing advertising of junk foods, certainly before 9 p.m, and then improving access to weight management services in the NHS. And what you can see in this graph that looks at the percentage of people supporting all those policies is that in each case, a majority of survey respondents support the policy. So far from the public wanting a sort of libertarian government when it comes to obesity and weight reduction, actually the public supports more government intervention in this space. And actually you could look at this chart here and conclude that actually the public at large is relatively nanny statist and wants quite a lot of intervention to reduce obesity rates in the UK. So that's it from me in terms of sort of whirlwind tour through some of the statistics on obesity. So just to summarize there, health inequalities in the UK are significant, and if you do this quick sort of calculation of obesity rates against health deprivation, obesity accounts for about a quarter of that variation in health deprivation across the UK. COVID has prompted many to lose weight, but there are regional variations, and I highlighted in that chart that people in London seem to be taking more steps now than people in the north of England, and that could contribute to widening health inequalities. Although stigma is a challenge to building public dialogue on obesity, the survey does suggest that the public does have some more nuanced views on the subject of obesity. They're not just interested in a blame game, and there is a recognition that government has a role to play in addressing some of the complexities around obesity. And lastly, and that last chart I think clearly shows it, is that there is a lot of support for government intervention in this space, whether that be advertising restrictions, improving NHS services, or restricting buy one, get one free offers, effectively increasing the price of junk food. So for the most part, the public isn't libertarian. They're actually quite in favour of a nanny state when it comes to obesity, at least. So that's enough from me.
Okay, Scott, thank you very much. Could I just check first off, because we did have one comment quite soon after you started, just asking what about Scotland, Wales and Northern Ireland? Although that was when you were showing some data from the ONS and Public Health England, which obviously is only about England, but is it correct that the survey that you've just done, it does relate largely to findings across the whole of the UK and Northern Ireland?
Yes, so the survey we've done with Opinion is a UK-wide survey. Unfortunately, that map I showed at the start was Public Health England data. And one of the sort of frustrations when you work in health economics is a lot of this data is dispersed, and sometimes you can only get the data for England.
Okay, thank you very much. Now, over to Avideh. I should have said at the start, apologies, that we do know you probably have to leave the call around 3:45. But you're very welcome now, and we'd love to hear what you'd like to say on this subject just now.
Thank you very much for the opportunity, and good afternoon to everybody. I thought in the 5 minutes that I have, I structure my talk around 3 important points. Point number 1 is the point that Scott just also presented right now about the complexity of obesity and how poorly it is understood also by healthcare professionals and healthcare systems. Point number 2 would be on importance of health inequalities and population at the highest risk. I think that's the sentiment of the discussion today. And of course, on the last point, I do want to focus on the role of industry and health partners to make sure that we put everybody in the right track. So on the first topic, which was complexity, and it was really good to see the results of the survey. People living with obesity completely acknowledge that it is a very complex condition. It's also important to acknowledge what Royal College of Physicians has clearly demonstrated back in 2019, mentioning, and here I quote, that it is important to the health of the nation that we remove the stigma associated with obesity. It is not a lifestyle choice caused by individual greed, but a disease caused by health inequalities, genetic influences, and social factors. So that was the view shared also by Royal College of Physicians, that when we talk about complexity, we're not just talking about that people living with obesity find it complex, it's also the science hasn't completely caught up, if you will. And if there is science, there is quite a gap between social narrative at times and the scientific evidence. On the topic of complexity, I like to also emphasize on the fact that it is complex because it is completely very multifactorial. We have heard it about many conditions in medicine. I'm a medical doctor by background, so the fact that a disease is a complex is something you hear it every single time. However, what I want to emphasize a little bit is about the interactions between biological factors, completely non-modifiable, hereditary, the genetic makeup of individuals, and also the drivers of weight regulations. To give you and put this into perspective, especially in the context of weight regulations, and to simplify it perhaps, we have one hormone, all of us in our body, that drives hunger, and 5 more trying to curb it, to really reduce it. So even biologically, we all have been, as a part of evolution perhaps, we all are wired to gain energy rather than lose energy. And of course, the topic or the importance of physiological set point for weight, which is quite scientifically studied these days. Just again, to simplify it, all of us, if we change nothing in our life, it's quite, and we live in Europe with the European diet and lifestyle, it's quite possible that all of us gain a 0.5 kilogram per weight every single year. So weight regulation is, as I mentioned, something evolutionary. It's shaped around saving the energy rather than spending it. And that's why we all know also, even if you lose weight, it's quite easily bounced back. And gaining weight after weight loss is actually quite a well-known phenomenon. So why is it poorly understood? The examples I would like to share with you is about comparing perhaps obesity with cardiovascular disease and hypertension. In a very simplistic way, if you think about modifiable risk and non-modifiable risks between the 3 conditions, they're exactly the same thing. For example, sedentary lifestyle, diet, smoking is a modifiable risk factor for all these three conditions. And of course, non-modifiable conditions are also quite similar between the three conditions. However, we rarely, if ever, come across a view that when you have hypertension, all you need to do is exercise more and perhaps eat less. Everybody knows that in hypertension, you seek help, you receive care, and you really across that can carry on with your life. So on the point 2, which was health inequalities, and really the picture shared right now was really nicely setting out that concept of variation of care that exists anyhow. And with COVID and other pandemics or any other situation that makes it worse, we also need to be carefully looking at it. It's also very clearly known that the significant socioeconomic, even gender and ethnic inequities that exist, and sadly these inequities across Europe and also definitely in the UK is becoming more gradient and it's becoming more steeper. So for example, women and children in low socioeconomic groups are most vulnerable, and sadly this can be passed on from one generation to another if we don't really take an action on it. And I'd like to conclude with emphasizing on the role of industry, for example, us in Novo Nordisk. How do we view it? How can we really partner with everybody, have this dialogue and really move us all forward? I think it's important to know that we do acknowledge prevention through a multifaceted programs are important. And here I can perhaps share with you one of the initiatives that we are very proud of it, Cities Changing Diabetes. Also in the UK, 2 cities, Leicester and Manchester, have been selected to be part of this program, which is really acknowledging that weight regulation and in the context of Cities Changing Diabetes, ultimately diabetes, is really a community story. It's not about talking only to changing diet or food industry. It's not about only changing health and sporting partners. It's really a collaboration between everybody to put the conversation in the right positive place. It's also important to note that healthcare professionals, doctors, nurses, are critical and key workers. Indeed, they do require to gain more trainings and educations around weight management and weight regulation. When I was in med school many years back, I remember I never received any training on weight management. It was only later on when I studied metabolic diseases and endocrine that I actually ended up learning a lot more. So understanding that not every healthcare professionals also have received the trainings to be able to tackle weight management or weight regulation is also one part of important role of industry to be able to work with academic units. And finally, it's importance of research and therapies that address multiple pathways of weight regulations. As I shared earlier, with hypertension and cardiovascular disease, nobody can only focus on prevention. Prevention, as important as it is, but providing therapies or solutions more than therapies, solutions, also medical solutions, to be able to support people who live with diabetes, with obesity, as well as support healthcare professionals who would really like to do the right thing for the people. And that would be one of the areas that industry is really focusing on, and of course research and development to be able to do that. So with that, I thanks for the opportunity and I hand it back to the next speaker.
Okay, thank you very much. It's many great points there, and we will come to discussion shortly after Paulette's had a chance to have her say as well. But also, I should have said that please do get your questions in to the panel. We will look to have as long as discussion as possible. But over to Paulette now. Thank you very much, Paulette.
Good afternoon and thank you. Thank you for the invite this afternoon. I hope I can do justice to the previous 2 speakers. What I'd like to talk about this afternoon is obesity around the issues of social care, public health type agenda and local authorities. Obesity is a very serious public health challenge. Adult obesity, and most worryingly, severe obesity is rising along with associated health and social care costs. Obesity impacting on people's lives now across the generations, affecting the quality of life by increasing our risk of developing chronic diseases, as highlighted earlier. Obesity also affects the quality of life that we lead and our and it gives us, we have psychological problems. We see issues with anxiety, depression, and low self-esteem. We also have seen in recent months how COVID-19 also affects those who are obese. The lockdown and those shielding and vulnerable have created additional burdens. The government's focus to date has centred on obesity-related costs and pressures on the NHS rather than on social care. The social care requirements for people with severe obesity are costly and include housing adaptations, specialist equipment, and carer provisions have increased rapidly over recent years, particularly over the last decade. Health inequalities have widened. This has been accompanied by wider inequalities and in both child and in adult obesity, with rates increasing amongst those from our more deprived communities and also from those from our ethnic groups. Effectively preventing and treating obesity will tackle health inequalities, and it has the potential to significantly improve the quality of life and well-being. In addition, and reducing health and social care costs. Social care has a pivotal role in boosting mental health as a means to support healthy weight management. I'm going to give you a local example. In Birmingham, we have approximately 23.5, which is basically 1 in 4 of our children enter schools and they're carrying extra weight. And by the time they get to 11 years old, that goes to 40.3%, and that is just under half of the children in Birmingham that carry extra weight by the time they get to 11. A higher number of obese children are actually from BAME backgrounds, and this is significantly higher in the deprived parts of the community. Our ambition locally in Birmingham is to be a city of growth where every child, citizen and place matters. So we have a look at how we can be a healthy food city. What we've done in Birmingham, we have 571 parks in the city, and that is more than any other European city, but yet a number of people using our outdoor spaces remain low, and these are also significantly reduced this year by the lockdown. The percentage of our 15-year-olds that achieve activities, well, that's 1 hour's exercise per week, is 12.3%. And we have a shift where people are changing and they're using, especially our young people, more technology. In order to tackle this, we need to take action, and we need to take actions on many levels. I know people have said that prevention is not the only way forward, but in Birmingham, as with other cities, we have 1.2 fast food outlets per 1,000 citizens, and we have 1.2 million citizens in our city. So we have to find a way to have healthier options. We in Birmingham embarked on something called a childhood obesity trailblazer pilot. And what this pilot did was help to focus the work that we were doing to educate our young people on different levels. So not just about what they eat, but also how they do activities and how we attach it to policy. We also work quite closely with the Milan Urban Food Pact, And this is a European partnership for action on creating healthy food environments in cities and town. And it enables us, in connection with networks of 193 cities across the world, to share learning and approaches on food, because you cannot do it in isolation. Now, I could go on forever, but I won't. But what I'll end by saying is, prevention is important, but we have to do it in different settings. We have to do the physical activity, we have to do the healthy eating support, but we also have to do systems thinking. The local authority or the local councils can't do it on their own. We have to work with local businesses. We have to look at transport to see and work with them. We have to work with the voluntary sector. We have to work with the health service. For us to really impact on obesity and the challenges around obesity, we have to have a systems approach where everybody has to work with the individual or with a community that's living with obesity, so that they don't see it as their personal challenge, but they see it as a challenge that we're all in this together. And I'll stop there. Thank you.
Okay, thank you very much, Paulette. It's sort of fascinating to hear about the lack of use, you said there, of the hundreds of parks in Birmingham as well. I'm coming to you live from East London here. I'm only a couple of miles away from the Olympic Park. And it's certainly been found that, sadly, the 2012 Olympics hasn't actually done much in terms of improving the sort of healthy lives of the people who live beside it. And it sounds like a similar situation where you are, that the facilities are there, but perhaps not as well used. I'm just wondering, before I open the discussion up to questions from people watching, I could ask Paulette and our other two panelists first, really to touch on that. One is, Paulette, especially, you and your colleagues in the local authorities also are the same people who are trying to do something with COVID just now. What is happening with obesity? Has it just essentially been left on the back burner because you're so busy trying to tackle a pandemic? And what is your sense when you mention the number of fast food outlets? Is it the case, really? I'm often told by doctors I speak to that simply, you can't outrun a bad diet. Is that the sense, of sort of a rule of thumb that you would also agree with?
No, I absolutely do not agree with that statement. And you phrased it really wonderfully. No, the idea is, if fast food outlets can see a way to make profit doing healthier food, the issue for me here is, how do we give the healthier option? The thing is, it's to give people choices. And many fast food places, the reason they do fast food is because they think that is the only choice in town. 10 years ago, many people out there were not vegans, they were not vegetarians, but that has become far more popular. With that becoming more popular, people have provided the types of food that people who are vegetarian, I know it's still hard to get in certain places, but you can still go to a restaurant now, a good restaurant, and you can get food for vegans and vegetarians a lot easier than you could, say, 20 years ago, when myself and my husband were going to restaurants, and my husband was a vegan and he couldn't get anything on the menu. So it's a lot easier. As part of the LGA work, we have produced a document because we absolutely feel in the LGA that this is key going forward towards our social care development and what we do as a healthier country. Because what it was seen was, during COVID, people have put extra weight on through shielding, through not being as active, and we have seen that disproportionately people that are from ethnic minority communities, people that develop get the virus, that they are potentially at higher risk of death and harm. So the LGA did take a really bold step by producing a document that I think it was released about a month ago, 6 weeks, where we are looking at obesity. We are looking at how to do systems thinking around obesity and working with others to challenge what's been done in the past, but also to look at different ways of working, the way people eat, the way people exercise, the way we influence policy around activities. We've looked through it all, but also to change policymakers. So as was highlighted by Scott, when you're looking at things relating to 2-for-1 fizzy products, to lobby on things like that, and also to take it to the House of Lords, so we have it at every level where people are looking at the issues around obesity and are looking to work in a more joined up way. And I'll stop there.
Okay, thank you very much. Avideh, would you like to come in at this stage before we go to questions?
No, fully agree with what was described just here, and really reflecting on impact of COVID. We do know, of course, COVID exposed any areas of inequalities. It's not necessarily just weight management. It does clearly show that there is, across the world, there is a link, a disproportionately higher group of people with obesity. If they do get COVID, they will be suffering with the severe forms of COVID. They will also potentially get more hospitalized. And when hospitalized, they can also develop dependency on ventilators. So these are the data, emerging data related with COVID that is, of course, quite concerning. I do believe the release of the obesity strategy from the government at this point in time is quite welcome. I think it was a welcome need because it would have been a lot more concerning to think that we are going to go into the next phase of pandemic without actually acknowledging it. So that's a positive step forward. The science behind why COVID hits people with obesity stronger is still in development. There's also that understanding with regards to diabetes and glucose. So all of this is emerging a lot more. I think the scientific evidence is developing quite faster. And I do think the release of government strategy in this period of time is quite welcome.
Okay, thank you. And Scott, obviously looking at COVID and obesity, there's no more famous a patient than Boris Johnson, who of course suffered very badly. And I think reading the Sunday papers, there was a mention he's now lost about a stone and a half and possibly managed to shed his cheese addiction. I think was blamed on his larger than healthy tummy. Is your sense though or concern that perhaps with the Department of Health and others so focused on COVID that the obesity strategy will be left to gather dust on the shelf for some time?
Well, I think the obesity strategy is clearly a welcome announcement from the government, and it's one of the welcome effects of the pandemic is that obesity has now got more attention because of the associated linkage between COVID risk and obesity. I think my concern really is that the strategy might not go far enough and it might not cover as many areas as it should. And I think Paulette made a really good point that what we need is a systems approach to dealing with obesity. And it's a complex problem and there's many sort of aspects to it. And we need to go much broader than what's in the current obesity strategy. Because clearly there's all kinds of ways that you could tackle obesity. And there's some things that the government's probably not thinking about in its obesity strategy that's relevant. For example, if you are in a deprived area, you might not go outside as much because you're concerned about crime in the area. And therefore, is crime reduction something you should be thinking about as part of a wider obesity strategy? Are we thinking about it in the whole and all these sort of complex issues?
Okay, now we're going to go to questions now, and the first person I'd like to invite to ask their question is Angela Chesworth, who I believe is the UK champion at the Obesity Empowerment Network. Angela submitted a question last night and has also contributed one on the little dial-in box. So Angela, if you can hear us okay, would you like to ask your question, and do please say who you'd like to answer it first.
Good afternoon, everybody. Can you hear me?
Yes, we can.
Great. The question that I actually put through yesterday was with regarding to access to treatments, because the strategy is focusing a lot still on the eat less, move more, which for me as a person living with obesity is extremely important for any human being to live a healthier lifestyle. But if you're living with obesity, it's so much more than what you eat and how active you are. There's so many complexities. So I would like to ask, would the panel, everybody, agree that increasing access to treatments such as bariatric surgery and medications would be a cost-effective move forward, both for the government as the NHS and actually for people who are living with obesity? Myself, I've had bariatric surgery and the NHS paid £8,000 for that surgery. 7 years down the line, I'm on no medication and haven't been for those 7 years. So it's cost effective that the medication I was on before my surgery was averaging maybe about £8,000 or £9,000 a year. So the government really is benefiting from investing in me. So should we not be using bariatric surgery more to help the people that are living with obesity?
Okay, thank you very much for the question. And just before I'll put that to Avideh first, because she is the medic amongst us. But just to note that you know, Scott's survey did actually show, even though it was the bottom of the list there, still 32% of people believe that the NHS should provide more people with surgical help. I think it's still quite a high figure for people willing to go ahead with that form of surgery. But Avideh, you'll know better. What's your take first on the question?
Definitely, and such a good question. I think it's fair to say that in the government strategy will be releasing a lot more details. So that would be one of the things to have an eye for and see if there would be more elaboration on what can be done. There is also the acknowledgement that in the strategy had been mentioning on a wider distribution and access to Tier 3 and Tier 4 services, potentially even combining Tier 3 and Tier 4 services. So hopefully one of the things that Angela pointed out is being able to actually go to those specialist units that can provide consultation for surgery and being able to provide that to those who choose to do it. You're very right. Even NICE found bariatric surgery as a cost-effective way. So I don't think it really is a matter of cost effectiveness. It's about really taking people with obesity through perhaps a tiered approach that right now exists, and every tier that we go, Tier 1, Tier 2, Tier 3 services, we're going to lose few people, especially context of today, inequalities. If people are living in a very marginalized part of the countries, they really don't have access to care, or they find it very strange to go through one system to another. That will hopefully, if we simplify the service so that people can get the consultation and the care they need at the point that they need it, that will be one step forward. I think that will be really helpful. I don't think with surgery there is question about cost effectiveness. As I mentioned, NICE has clearly mentioned that it is cost effective. It's perhaps to build a system around it so that we actually meet with people at the stage that they are in. Many people do not want to have surgery. Many people would like to try medical approach. Many people would probably actually need to be engaged and actually being seen by somebody who can understand, listen to their needs, and being able to then take forward for the best option that exists at that point.
Okay. Paulette?
I must admit, for a second, I appreciate it, because I truly believe I am one of these. It has to be an individualized thing. If you're treating the person as an individual, you know where they're at the time. I'm a great believer that prevention is better than cure. But if the person is at a place where they need that intervention and they are psychologically ready for it, because I have known people that have had the surgery and they've not maintained the weight loss because they weren't actually ready for the surgery. So for me, I believe we treat the person as an individual. If that person has had all the checks and balances, they're ready for that surgery and ready for that journey they need to go on, I actually believe it can be a cost-effective way of dealing with obesity. But it cannot be a first choice. It has to be a last resort where you've gone through, as Avideh said, all the steps to get there. Thank you.
Okay, and Scott, so basically the survey is showing almost 1 in 3 people believe the NHS should provide greater access to such surgery. I'm just wondering in your answer as well, could you just touch on a couple of the questions that have been raised by others, Helen Cherry and Anne Vincent, who are also asking a little bit more about the research, how many responded and so on, and quite where it takes us. But if you could focus on Angela's question primarily, please. Thank you.
Yeah, so I think the only thing I'd add on Angela's question is around access to bariatric surgery and how that varies across the country. As we know, one of the ways that health inequalities evolve in the UK, and one of the issues here is that there are differential access rates to treatment, or even things like seeing a GP at a regional level. So the Royal College of Surgeons had issued a statement a few years ago on the fact that access to bariatric surgery is uneven across the country, and therefore if we do want to widen access to it, and there are these sort of benefits and it is cost effective, I think really dealing with that postcode lottery has to be addressed.
Okay,
and then going to move on the survey about the sample size. So this was a nationally representative survey of 2,000 adults, so it's a good statistically robust sample.
Okay, thank you. Just moving on to some other questions. There's one here from Michaela Hack, and I think I'll put this to Pauline if I may. A very interesting question. Where should accountability for reducing obesity sit, with the NHS, the government, or at a local level? And obviously you're at a local level, essentially, you're right on the front line. Can you do it yourself? Probably not. You know, is it for everybody, or should somebody be taking the lead?
Well, I'm going to cop out here, because what I'm going to say is it has to be a systems approach. You cannot say that it has to be at a local level, or the government has to take total responsibility, or it's got to be the NHS, because it won't work. It has to be all of us coming together as a system to work with the individual or with a community through public health or others, to make the changes through policy, locally, government through national policy, businesses and what have you. But I do believe you cannot put the blame on, or put the onus on, one agency. If I was to put it on one agency, I would say public health play a big part in this, and they sit in the local authority. But I think if we're going to think bigger and think differently, we have to move away from blame. Each bit has their own part to play.
Okay, thank you. Now let's move on to fast food, because fast food is raised in the obesity strategy. If any of the people watching know London, then they may be aware that the Mayor Sadiq Khan did introduce restrictions on the London Underground in terms of actually advertising fast food products on the tube, which is, we don't really know whether it's been successful or not yet, and there may also be linked arguments about whether it's then deprived Transport for London of income. But we've got a question here from Sam Winter, which asks, what are your thoughts on advertisement restrictions on fast food, which set to ban fast food ads before 9 PM? And I believe as well that the obesity strategy looks both at TV advertising and online advertising. So Scott, could you kick us off on this one, please?
Yeah, so I think there's reasons for sort of a positive view on it, and there's also some reasons to be a bit skeptical. So on the sort of positive side, we do know that advertising can influence consumer behaviour, particularly amongst children. So if we want to sort of get younger people into good sort of eating habits, this could be a good route to go down. And I think the other thing to consider with respect to these kind of advertising bans is how it might impact the behaviour of food manufacturers. So could it compel food manufacturers and drinks manufacturers to produce healthier products so they can advertise before this 9 PM limit? So there's sort of ways that you could envision there being positive change, so particularly influencing the behaviour of young people and then getting producers to change their products. I think one reason to perhaps be sceptical is the advertising landscape has evolved so much in recent years, and can we really tackle all online advertising? I'm a bit doubtful. And I think particularly what a lot of producers of all kinds of goods are doing now is this kind of subtle advertising, where it's not it's not an advert on a website, but it's using, for example, influencers on social media. So you pay someone to market your wares on Instagram or some other social media platform. And can the government really get around that kind of advertising? I'm skeptical of, and that kind of advertising is becoming more and more important.
Okay, just before Avideh has to go, there's a question from Helen Cherry. I wonder if Helen can hear us and would like to ask it in person. Is Helen available to be unmuted?
Okay, yeah. Yeah, I'm someone who has both type 2 diabetes and heart disease, though I'm not obese, and that's more by luck than anything probably. And I was a social worker, and I've worked with a lot of people when I worked in physical disability team who struggled with obesity. And I understand both from my own personal experience and from some of the people that I worked with, that there are huge psychological issues around food, from compulsive eating to carbohydrate addiction, both of which I would say I suffer with. And this seems to be largely ignored by dietitians and GPs in my experience, both my own GPs and bringing people to GPs when I was a social worker. And it's extremely difficult, I think, for people to have the emotional energy, and it does take huge amounts of emotional energy, I believe, to engage with losing weight when there are so many other things happening in their lives, with worries about how to make ends meet, etc. You know, we were talking about injustice. Do you all recognise that, and how do you think that can be addressed?
Avideh, would you like to go first?
Definitely. Such a good question, Helen. And getting back to the point I made earlier, it's about really the complexity that we're describing is how little we understand the mechanistic of weight regulation. You did point out that regardless of your actual weight, the relationship, the psychological relationship to food is something well known and well studied across the world. Regardless of which diet you follow, if you live in Asia or you live in Europe, that attachment that we all have to our food, culture, being together, you know, that whole perhaps ritual that exists with food is something which is one of the elements of the complexity of obesity, that you can't just ask people to eat less, because you will end up asking them to also be less sociable. We all know that we always enjoy eating amongst family and friends. You know, social distancing these days is going to stop it. But in reality, for us to be able to incorporate that, and you mentioned dietitians and GPs, again, going back to that whole thing that perhaps GPs have not been even given that level of training that they require when it comes to being able to manage the weight and the complexity that exists around it. But in that context, you really need to address, for you to build or remove one of the behavioral habits that drives that attachment to food, and especially certain level of food, you need to build a positive perhaps habit around it, which stops you from having that sedentary lifestyle, or being able to go for the snack. Snacking is something which we all do, especially if you are doing a late night TV, for example. So it's about addressing that. In order to get to that end goal, you cannot just simplify it by saying, coming up with a very paternalistic approach of this is what you need to do as a person living with obesity, or just eat less, because you did figure out, and I also described it, that even biologically, what happens to our brain when we have something with high fat and high, for example, sugar, is very different versus when we get a protein into our body. So very, very good point. I do acknowledge that we need to address it a lot more holistically rather than just coming up with one blanket approach. And a lot more needs to be done by breaking it up into behavioral habits that are important, building those positive habits that, ultimately lead to people having a healthier lifestyle.
Okay, thank you. Paulette, you must hear from people all the time with very complicated life stories, and just, the desire to change behaviour. Then when that meets real life, it can make it an almighty challenge. What did you take from what Helen said there?
I thought that was a really interesting point that she made, because what I found in my years of being a health professional and going into politics and what have you, the food is a byproduct sometimes of what is going on in somebody's life. And the issue around food, if you can work with them to sort out, or wherever in the system they need to be, to sort out what the issue is that's causing them to have that behavior, or causing that anxiety, or whatever that issue may be, you can sometimes break the behaviors that way. And so it was really interesting when Ellen said about the fact that I'm not overweight, and I've got diabetes, and I've got, I think she said, high blood pressure, and I do like carbohydrates. But the thing is, she's just thinking, because I'm not overweight, I shouldn't, and I'm sure she's not, but I'm gonna say how I took it. She can't understand why she should then have those two conditions. But some people's metabolic rate, it doesn't actually show on them. So she may not have a lot of external fat, but inwardly around her organs and wherever else, she could have inward fats. And sometimes it's finding out what is causing that person to head for that chocolate, or to head for that thing that is more carbs. And I'll just end by saying to Ellen, I work for very long hours, and sometimes I haven't eaten a great deal during the day. And Ellen, what I do at the end of the day, I'll say to my husband, oh, I could kill a bar of chocolate. Now, I know I shouldn't be saying this, but I could kill a bar of chocolate. And then what I then do is, the chocolate seems to fill something in me that I haven't eaten, because I haven't eaten all day. But if I had stopped for 10 minutes during the day and I had eaten properly, I probably wouldn't have that craving. And I know what the issue is, but I need to address it. And I'll stop there. Thank you.
Thank you. It's obviously so much about planning ahead, and when you're busy and perhaps don't have a healthy snack or a healthy lunch with you, it can make you grab for the wrong things, can't it? Just go back to Helen, actually, if I see you're still with us, Helen, and just wondering what you made of those two answers and whether you found that helpful.
Yeah, I mean, very interesting. And I've just put in the box actually that I do have a family history of both diabetes and heart disease. So I always, I think, had a predisposition towards that. I also have a disability, so I used to play a lot of tennis when I was young. I had polio when I was little, lots of ankle surgery. My ankle's fixed now, so I can't do the exercise that I used to do. So when I was younger and was able to take lots of exercise, my bad eating habits, if you like, didn't really show. My addiction to sugar and fat, and that's what I'm arguing about, really. I'm arguing about addiction. I'm talking about addiction. You know, we talk a lot about, I mean, I've listened to lots of the presentations, and there's been a lot of talk about alcohol addiction, addiction to gambling. There's been no talk about addiction to food. And I think food addiction is a huge issue that goes largely ignored. I mean, how many people actually know about Overeaters Anonymous? Certainly no dietitian in the course of my work that I ever spoke to had any knowledge about Overeaters Anonymous. But they all had, you know, everybody knows about Alcoholics Anonymous or gambling or narcotics. You know, I don't think there's I mean, what I'm trying to argue is I don't think there's enough recognition of the Avideh, you certainly mentioned it, enough recognition. It's too much of a medical model, I think, around obesity, and not enough of a psychological model. So I think that's what I'm arguing. Stress, you know, I said about Paulette, I used to come home, I was safeguarding lead, social worker safeguarding lead, dealing with all the abuse cases with older people. And I used to come home and I would use food as a sedative. I would use chocolate, carbohydrates as a sedative in the same way as other people use alcohol or smoking or drugs. Luckily, I don't drink, or God knows I'd be in terrible trouble, you know, but so seriously, I think, you know, I'm interested in the Labour Party taking on the psychological aspects of food, really.
Okay. Helen, thank you very much for your question and for your response as well. We're going to move on to try and allow as many people to get in as we can. I think next I'm going to ask Scott if you could just look at a couple of questions that have popped up on the little Q&A box. I'll take them together. One from Sophia, who mentions Michael Marmot's report. He is obviously the professor at University College London who does the sort of pioneering research into the sort of how long we're living well and how that has been affected. And recently by austerity, he suggests that we've stopped enjoying as many good years as we might have done previous. I think from memory it's around 78 might have been the average for men. And also then the question just below it from Carl, who basically says that the recent obesity strategy focuses on food labelling and advertising, which is overly simplistic. Scott, what would you say to those 2 points?
So on the sort of the life years question, sort of years in good health, is we know from the data that since the millennium, you have seen a sort of widening in life expectancy inequalities in the UK, and you see all these sort of news stories going around in London. There's usually sort of a postcode district where you can walk down the street and there'll be a sort of 10-year gap in life expectancy, and you are seeing this growing debate around sort of deaths of despair. A lot of it's been in sort of the US, but there is some of this debate in the UK as well around how the economic environment is sort of translated into all sorts of issues from drug addiction to obesity, excess weight, and so on. So clearly that's important. And then sort of on the government's obesity strategy being too simplistic, I think I'd agree with that. And as I was saying earlier, I think that the strategy isn't being broad enough, and we do need this sort of systems approach that looks at all kinds of issues. And I think one sort of omission from the strategy at the moment, as I see it, is around some of the price tools that could be used. So we've had the soft drinks levy. Are there more kinds of sugar tax measures that could be adopted? And are we not seeing these kind of policies being floated because the government doesn't want to spook industry too much? But we know from all kinds of other things, such as alcohol, for example, that price can be an effective mechanism for changing consumer behaviour. So do we need to do more to change the price of unhealthy food, and can we use tax to do that? I think that's a pretty big omission from the current strategy.
Okay, thank you. Now, there's an interesting point being made here by Paul Chesworth. I don't know, Paul, if you're keen to ask it live to our 2 panelists, or you'd like me to ask it for you, Paul. Are you there?
No, you can ask the question, that's fine.
So basically, you were raising this curious point about the rule on advertising, and this is maybe a challenge for Scott to know the ins and out of the proposed restrictions, but the sense that basically saying, will the companies who advertise the delivery of food on TV be included in the ban before 9 PM as they don't actually advertise the food? Now, that's an interesting point, because I know in London there's been various issues about the tube advertising where it's like the perverse situation where something that is found to be containing fat was banned, and such items included butter, but of course butter is entirely fat, so of course it would be banned. So it's quite how the restrictions work in practice. Scott, can you help us out here? Well,
I think I'm not entirely sure, but I think we don't have sufficient detail yet to be able to answer that question. I'm afraid I can't shed more light on it.
Paul, would you like to see whether you feel that sort of good intentions in drafting these new rules may be frustrated by practical situations in real life? Is that what the point you're trying to make?
Yeah, exactly. It's something that is a loophole, as people refer to, and the money that's spent by these companies advertising the delivery services must be absolutely phenomenal. And it's all predominantly aimed at what are classed as fast food outlets, not the most healthy. However, I do think that some of the fast food outlets do quite healthy options, and they do get a lot of bad press from this blame society that it is only the fast food that's causing an issue, where, as we have said, and Paulette made the point, is for anybody who lives with obesity, they need to have an individual approach from the support services, and the way that that's done is making sure that the funding is provided by the CCGs to the weight management services. They actually hold the purse strings for any support that's given to anybody, because the complexities for people living with obesity far outweigh the number of complexities involved that regulate a person's weight. Need to have individual support. So I think Paulette's point on that individual treatment is spot on, but it's how do we ensure that the CCGs across the country fund these services without being a postcode lottery, and then that would actually take some of the fix one of the small elements regarding fast foods, because fast foods can be healthy if it's the right type of food. So they're kind of tagged with a bad reputation in some areas without due cause. To be fair, it's
very good question. Let's put that to Paulette. Is there a postcode lottery, as Paul's suggesting there, in terms of the ability of CCGs to fund services?
I absolutely agree with what Paul's just said. CCGs are key to this, and across the country very much depends on what they put as a priority. How I see this going in future years is through that new mechanism of the integrated commissioning systems type approach, where I keep saying it, you're looking at it as a systems approach, and where the funding is not necessarily coming from the top of that system, but they see it as a priority. So funding will be targeted towards it, because at the moment it's very hit or miss. Everybody talks a good talk, but it very much depends on where you live. It's dependent on the service you then receive.
Okay, thank you. Now, is Gail Barton there? Gail, would you like to ask a question? You make a good point here about having to change your own diet and certain things that are otherwise generally recommended you can't eat. So that leaves you in I guess, a degree of a predicament in terms of following the normal rules, if you like. Gail, would you like to make a point?
Absolutely. I mean, if you go on the internet, there are support groups all over the place for people who are developing food intolerances left, right and centre, whether that's gluten or dairy or soya, or in my case, pretty much everything. You know, I think the way that we have been treating our bodies for the last 40 years has been hugely detrimental, you know, in terms of the food that we've been ingesting, the air quality, the chemicals in our homes, and it has just made our bodies super sensitive and much more prone to a huge range of autoimmune conditions that are costing us so much money and will continue to cost us so much money. I mean, you're probably aware of the, you know, having a very sort of low carb diet has proved to be very successful in reversing type 2 diabetes. But when you're working against, you know, the addictive properties of carbohydrates, just having a weight management plan is nowhere near enough to help people make those lifestyle changes to reverse the conditions that they have.
Can you tell us as well, because people may be interested to hear if you're happy to share, but what is it that you now base your diet on? You know, how do you get enough calories each day?
Oh my goodness. So it's quite difficult at the moment. I'm not sure. I don't want to start putting things out there, but I'm not sure whether I had COVID earlier in the year and then, you know, my sudden inability to digest other foods is connected to that. I don't want to say that's definitely the case, but it just seems coincidental. But it's very sort of meat, fish and veg heavy. I've cut out the snacking, which when my daughter was little, we were all told, you know, give your children food every couple of hours. But what we've actually done is brought them up in this culture that they are constantly eating. And when I was eating carbs previously, I used to feel hungry I would eat, I'd be fine, and then I was like the class act for the hangry. You know, the hungrier I got, the more agitated I got. But actually, taking carbs out of my diet has just completely removed that. It feels like my blood sugar is very stable across the whole day. I'll have something like fish for breakfast, you know, meat and veg for lunch, you know, and maybe like a poultry and more veg for tea. I don't feel hungry at all, because it's not the lack of food that's making me hungry, it's the carbs and the sugar that were affecting my brain chemistry.
Yes, I got you. Paulette, what do you make of that? It's fascinating to hear the way, you know, the change in diet can change your whole life, really, and also effectively sort of short circuit some of the natural triggers in your brain that they crave certain, obviously the wrong types of food, as you were alluding to before. And I just wonder as well, the one thing we haven't come on to, I wonder if you could touch on too, is what's happening in schools. I know here in where I am in London, the schools are quite precise about what they'll feed children. Do you have something similar in Birmingham with they try and give the kids the right meals?
Well, we did have until COVID, because a large number of our schools now in Birmingham, they only give a packed lunch. They don't give a cooked meal. And when you have the types of inequalities we've got in the city, and you've got the types of poverty and what have you, some children really are not having a hot meal throughout. They're not having a hot meal. So there are issues around the school diet at the moment because of COVID, but they are trying their best. Before the children went back to school, the council did make an agreement that every family that needed the extra support, they would give them £3 a day to help them to get food, so that at least they had to spend it on food, and at least we knew something was going into them. But whether it was the right type of food, I can't put my hand up and say that I know or not. Relating to what Gail was saying, she's spot on. The other issue I'd like to bring into that is many women that go into the menopause, they find that they become very intolerant to certain carbs and certain other types of food. And I think sometimes I have to agree with Gail that sometimes your body is just, you're eating this heavy, stodgy sugar, carbohydrates, and you just don't feel well. You feel heavy all the time. And so I do believe that sometimes our body just gives up on us and rejects it and says, I am having no more. So I don't want to add to what Gail said, because I think she's spot on, but I think we need to start teaching our young people earlier on. It shouldn't be that they get to the age where their body starts giving up on them. If we start to, as they do in countries like Sweden, and believe it or not, even parts of the Caribbean, where children eat healthily, they eat lots of fresh food, they don't eat the starch that we have here and the fast food, then their system develops on that and they're able to grow and maintain that. But I don't want to add any more from what Gail said, because I truly believe she's spot on. Some of us, our bodies just say no more and it gives up on us. And we have got to follow suit, or we find that we become ill and you get the fibromyalgia type conditions, the muscle aches, the type 2 diabetes, the arthritic type condition. Your body keeps warning you and warning you and warning you till you start living and you're on that journey towards ill health. And for me, we have to erase it through doing far more prevention earlier on and looking at a systems approach and not expecting the individual to find it out by chance and going into it. And I'll stop.
Thank you very much. And I think probably the last question for today, I'd like to invite Sophia to ask it. She again was taken by what you said earlier, Paulette, about this late night bar of chocolate. But she's making a very interesting point here, and I wonder maybe Scott could touch on this if Sophia would like to ask a question. No. Sophia's not there. I shall read this out then, Scott. You've probably seen it in the little box, just for anybody who hasn't seen it. She's basically saying, what an interesting comment by Paulette about working all day and not taking a break, and this leading to unhealthy snacking. What is the role of employers and job design and availability of food when we are at work? Now, I know from my job at the Evening Standard, many health workers are concerned that the vending machines that the NHS hospitals have, and they say this is unhealthy, but others will say, well, hang on a minute, if you're on a night shift and it's 2 AM and the canteen's shut and the shop's shut, then that can of Coke and Mars bars all you've got to get you through till 7 AM. So is there a duty in the obesity strategy on employers to provide healthier food for their employees? And if not, should there be?
Well, I don't recall it being in the strategy at the moment, but just on this point around whether there is support for that kind of measure, actually in sort of the broader opinion survey that we've done, we did ask a question around who people would be comfortable speaking to about sort of losing weight or getting advice on losing weight from. So, you know, whether it be family or friends or going to your local GP or another health professional. And from memory, an employer was at the very bottom of that list. I think a lot of people don't want their boss sort of dictating how they should eat, and I think that for many people that would be a step too far, and that sort of comes out in the survey, is people really don't want their employer intervening in this space.
Okay, interesting, very interesting. Listen, thank you both very much, Paulette, for giving all this time, and Scott for all the research you've done there as well. And obviously thank you to Avideh and to Novo Nordisk for helping to sponsor this event. We can sort of draw it to a close, but the one thing it does make me wonder, and I don't know whether Scott or Paulette would like to sort of have a last minute or two, is just quite what the Eat Out to Help Out scheme may have done in terms of our fight against obesity. I'm pretty sure the other day that the statistician from Oxford University, Carl Hennigan, was pointing at the last bank holiday in August, when I think was probably the last day that the scheme worked. And there was a sense that that may also have been the start of the uptick in cases, just with people being out and about. And obviously we know from the government's obesity strategy that quite often we're eating 200 to 300 more calories than we should each day. And when you're eating out, it's very hard to work out how many calories are in the dish. So has Rishi's Dishes not done us any favours? What would you say, Paulette?
For me, Eat Out to Help Out. As a local politician, the economy, they needed to kickstart it, because Birmingham is a city of a lot of independent hospitality venues, and it really needed to get it started. But the challenge is with the obesity strategy, no, it has not helped it at all, because people have gone out, the food was a fraction of the price, and people have absolutely indulged. They've indulged, and to the extent where, to be honest, they've not really kept the social distancing. It's been very difficult for people to keep the rules around COVID, and we have seen the after effects of some of that are coming through at the moment. But saying that, I do think that some of that work around Eat Out to Help Out was needed on a psychological level, because people were tired of being in the house, they were tired of feeling enclosed, and this was one way for people to get out and about and to actually mix, not closely, but mix with others. What we need to do, if we're going to do this sort of thing, is to ensure that we educate people, that they don't get confused and they understand what the rules are, because the friction is between the economy and the long-term issue of obesity in this particular area. And I'll stop there.
Thank you very much, Paulette. Scott, you get the last word, and thank you again to the Social Market Foundation for organising this, to Novo Nordisk, and thank you as well to so many of you for tuning in and staying with us throughout the debate. We hope it's been useful. Scott, the floor is yours.
So all I would add on top of what Paulette said is, if you look at some of the survey data that was coming out even before Eat Out to Help Out, it showed about 2/3 of us had gained weight since we entered lockdown back in March. So to the extent to which the whole sort of pandemic has been injurious or caused us to gain weight, that's been going on before Eat Out to help out with, a lot of us have been exercising less, a lot of us have been comfort eating, and then, as Paulette was saying, a lot of us have indulged throughout August. And I think as we sort of re-enter a period of new lockdowns, local lockdowns, these issues are only going to deepen and get worse.
Okay, thank you, Scott. Thank you, Paulette. Thank you, everybody, for tuning in. And that's it from us. Thanks a lot. Bye-bye.
Thank you.